Good morning, everyone. Thank you for joining us. We're so excited to have you today for our first event of our monthly Child and Adolescent Professional Development Series. I'm Lori Kehoe. I'm a member of the outreach team at SunCloud Health. We provide integrated, nuanced treatment at the residential, PHP, IOP, and virtual for adults, and PHP and IOP services for adolescents ages 12 to 17, focusing on treating the whole person. If you're interested in learning more about our services, my contact information, along with my partner Christy Orr, will be included in the last slide for your reference. To make a referral, you can contact me directly, or you can call our intake number. Please note that to receive your CE credit today, you will need to remain on Zoom for the entire presentation. Also, you will receive an email including the quiz and the survey. So please complete those to receive your CE certificate. You'll be receiving an email from Tammy, who handles that. Today's speaker, Colleen Kestel, began her clinical journey as a diet technician at a residential treatment center as she continued her education and earned her clinical licensure as a registered dietitian. Colleen then earned her master's degree in business administration with a concentration in healthcare. With this advanced degree, Colleen led a team of dietitians as the director of nutrition services for RTC, PHP, and IOP levels of care. Colleen has experience with treating co-occurring addiction and eating disorder populations at all levels of care, including outpatient. Colleen then combined her passion for nutrition and operations and was promoted to Assistant Director of Operations. Within this position, Colleen assisted in the development and operations, including but not limited to RTC, PHP, and IOP for both adolescents and adults. During this time, Colleen supervised and led an extensive team in clinical operations. Outside of operations, Colleen has experience working individually with patients of all ages and families regarding their relationship with food, body, and overall functioning. Colleen believes addictions do not discriminate. All ages, genders, and backgrounds deserve a chance at improving their outlook on life and doing so through gentle nutrition therapy, intense group and individual therapy, and joining a diverse community to no longer feel alone. In 2022, Colleen co-founded a Joint Commission accredited IOP and outpatient program in Will County as she recognized the need for quality treatment for mental health and eating disorders. Colleen returned to SunCloud in 2024 as Director of Operations and Compliance and is now assisting with program growth and development. And without further ado, I introduce you to Colleen Kestel, and she'd like me to remind you that she'd really love this to be interactive. We were hoping to be able to have a raise your hand option today, but what I'd like to encourage you to do is as questions come up, that you put them in the chat, and then I can kindly pause Colleen and let her know that you have a question, and we can keep this as interactive as possible. So thank you again for being here. Colleen?
So thanks so much, Lori. Hi, everyone. So excited that I can be meeting with all of you on this Friday. Before we get started, I'd love for you guys to just send in the chat what some of your roles are so I can get a better understanding of the audience and try and get to know you. So while we're talking, just go ahead, thank you everyone for doing that already. Amazing. All right. Wow.
Wow.
Such a great variety. I definitely would love to spend some time with you guys. Very cool. Okay, wonderful. So you guys are you know in the field and understand the importance of mental health. So first, I want to thank you and show appreciation for what you do for our community. Definitely something that's extremely important. Um, like Lori said, please be interactive. I would love to hear from you guys as we're doing things. So go ahead, put in your chat if you have a question, or sometimes I might ask a question, and I'd love to hear some of your responses. Okay. Oh, Emily Taylor gave a good point. She's not seeing others' responses. Um, so when a question's asked, I'll be sure to ask the question since you guys can't see it before answering. So just so you guys know, we had therapists, school social workers, interns, LPCs, LCSWs, LPC or LCPCs. We have nurses, we have a psychologist, we have a psychometrist, a lot of adolescent, adult family work, dietitian, everything. You got it. We named it. LSW. Awesome. Okay, so I'm going to get started. Great. Thanks, Lori. All right. So as Lori discussed, we're going to be talking about body image and disordered eating in the school population. With that said, I might be plugging in some other bits and pieces of information, and it would be great to get your questions as we go. So what I would love for us to go over today is our different types of eating disorders. I don't want to assume that all of us know what those look like, and I'll give you just a little bit of a detail for each one. In addition to eating disorders, we're going to look at what body dysmorphia is, how we want to address and recommend different levels of care and what those are, and then what your guys' role is and how we can collaborate together. All right, so did a lot of you know that there are 6 different types of eating disorders? Some of you might be most familiar with anorexia and bulimia. We do have 6 um, eating disorders that are recognized by the DSM-5. First, we have anorexia nervosa. Something to keep in mind that there is a difference between anorexia and anorexia nervosa. Okay, so anorexia is also a medical term. Anorexia nervosa is a restriction of calories, okay, with the intention of losing weight, okay. It is not, sorry, age, weight, gender does not discriminate with eating disorders. So that's one thing that we're paying attention to. It's typically accompanied by the desire to change or manipulate the body shape and size, with a very intense fear of gaining weight or having a certain number. So we consider like a feared weight. Someone was like, in my mind, I am wrong, bad, or unhealthy if I get to this number, no matter what the scientific reasoning of that number is. So people might have behaviors that interfere with weight gain. Next, we have bulimia nervosa. Bulimia is a binge type behavior or just your standard caloric intake that involves a compensatory behavior, such as the use of diuretics, laxatives, purging behaviors, excessive exercise behaviors, anything someone could do to like expend things from their body. So our body knows how to process and we create waste. And this is trying to like speed up that process. So a lot of times this also is associated with a body challenge of wanting to manipulate that. Okay. Third, we have binge eating disorder. This is where we kind of have a loss of control of what calories we're able to consume, that we don't see the behaviors of wanting to decrease the calories. Things might be trigger foods, which would include the lack of ability to have control if you walk in a kitchen and there's a candy dish on the table, or having access to ice cream in the freezer and not being able to stop after one serving. It could be sneaking behaviors, hiding behaviors, always thinking ahead of when am I going to get the next food. it does not correlate with their hunger and fullness cues. So those receptors are no longer active, or at least not honored. So a lot of this could be emotional or it could be physical. This does not have the disruption of the body image. Then the fourth one is other specified feeding and eating disorders, which is known as OSFED. OSFED is a diagnosis that kind of is a catch-all, that we're just not able to meet the specific criteria of the above three, but we still know there's something going on. So some of these have certain durations, such as a certain amount of weight loss within 6 months for the diagnosis, whereas maybe they have all the behaviors but haven't had that weight disruption, so it could be classified as OSFED. Unspecified feeding and eating disorder is kind of like we can't pinpoint one of the above three either. They don't meet the criteria, and they might not have the body image or the disruption of calories in their mind. And lastly is avoidant restrictive food and intake disorder, also known as RFID. This one's a little bit trickier. This is often not associated with mental health. Avoidant or RFID is a very excessive picky eater. So think of 4, 5, 6-year-olds and how picky they are when they're eating. That is normal for them as they're trying to explore and understand what they like and don't like in different textures and smells. This is much more aggressive type behavior throughout the generations. So maybe someone feels that like they can only consume things that are crunchy, or they have a fear of crunch. And this is a fear of putting it in their body, not a fear of the taste or calories. So it would be similar as if like you had a cup of gasoline at my desk. I would know not to drink that. Whereas if I had a cup of coffee, I'm able to drink that. Yes, Lori? Oh, you're on mute, Lori.
We have a question. What is the
Yeah.
difference between feeding and eating disorders? Feeding issues and eating disorders?
Yes. So this is just a coverall, given the fact that it is the ability to eat and be fed. Do we have another one, Lori? No. Okay. Um, so with RFED, I would know not to consume gasoline. It could be based on the color of it. It could be based on the smell of it. Whereas someone might feel that way about a food item as well, where we know our body is allowing us to have that piece of food, but there's something in it that's not letting us consume it. Okay, so this can be really damaging to their nutritional status, given that the food group that they're not able to consume has a lot of nutrients. So they might be consuming the same 4 things every day. Okay. My summary of these is if someone has a challenge of being able to nourish their body, we want to help address it and fix it. So yes, the diagnosis is very important to determine what the best treatment plan is, but in order to offer individualized care, I want to look at the symptom, the risks to the body, and if we can determine what the reason is, that is a huge bonus, but we're not always able to determine what that reason is. With all those factors included, then we could start addressing the behavior. What's also important is everyone's timeline is going to be different when we're treating eating disorders, that depending on how someone is able to jump in and get started will kind of depend how long this is going to take. So by no means can we sit down with a 14-year-old who was diagnosed with anorexia and just say, okay, you have to eat your food. If that was the answer, then my position wouldn't exist, and a lot of you wouldn't even be attending this webinar, because it's not helpful. So a lot of times that's where parents and friends and family want to be able to provide support of like, okay, I'll just eat the pizza with you. But there's so much more to that. Any questions on the 6 types of eating disorders that we're discussing? please keep in mind, eating disorders do not discriminate. We have all different walks of life, different age, different genders. A lot of times people assume anorexia is a white female young body disorder. That is not the case. We are seeing a lot of other genders and ages. They just weren't recognized, or they weren't able to receive the help that they thought. So years ago, we weren't seeing many males with eating disorders. It's not that they didn't exist, they just weren't sure how to receive that treatment. Earliest cases, I have seen as young as 7 and 8. And I have also treated as old as 74. I see, how does eating disorder play a role with someone with ADHD? Really good question. ADHD is like an additional complex disease that is added. ADHD could be a distraction to their hunger and fullness cues. It could be misuse of energy, so not recognizing that someone is hungry. It could be rapidly wanting the food that quickly digests, so like high sugar, high carb items that aren't necessarily providing all the other nutrients we need, such as protein. So ADHD, I would say like that again is really important when we're looking at case by case for individualized care to see how is the ADHD impacting their ability to sit down and eat and the foods that they're choosing. All right, medical concerns. My point of sharing this with you guys is because I want you to see and understand all these things that are going to come up. One thing I have recognized in the field is a lot of these symptoms are not important to someone. They don't have the ability to understand they're important, I should say, um, for someone until they start to physically see it. Okay. So, like, example, depression and anxiety, they can't physically see that on their body. It might not be important. Dehydration, sure, I'm thirsty, but it's not negatively impacting me. But when I start growing hair on my face, or I start having a lot of ulcers in my mouth, or I'm losing hair on my head, that's when I'm going to start taking it seriously. So I see this a lot with the younger population. And fortunately, our bodies are just so resilient and strong that we can handle a lot of change and negative impact, that the eating disorder isn't going to negatively impact us overnight. So that's what's just a little bit scarier about eating disorders, that there's a long-term history of damage that's building up and building up before we might recognize it's a problem. Whereas if you fall and damage, if you fall and break your arm, you understand that your arm's broken right away. If you have diagnosed with a disease within your body, you know that right away. So a lot of this takes some time. So because of that, the eating disorders can stay a secret, and that's what keeps us sick. A lot of, I'm going to say, mid to middle age patients are recognizing this a lot more and taking this a lot more seriously than our younger population. Lori?
Someone is asking, actually, it's Sonia, is asking, is there a general timeline for how long it takes to develop refeeding syndrome?
Good question. Okay, so refeeding syndrome, for those of you that don't know, refeeding syndrome is a risk of someone who has bulimia and or anorexia, which, by the way, you can have multiple. Bulimia or anorexia, whereas we are restricting so many nutrients to our body that our organs start to develop some failure. So most importantly would be the heart. So we're losing the electrolytes that make our heart work. So things that are extremely important for life. Refeeding syndrome is recognized with significant weight loss. So it also is a medical concern when we have someone who maybe has been, like we saw a lot of like prisoners of war with refeeding syndrome. So refeeding syndrome does take some time. Some patients with anorexia or bulimia may never experience refeeding, which is amazing. We don't want to get there. but every case is so different. So I really can't answer what a timeline is, but it's not going to be days or weeks. It's going to be several months, potentially several years. What's also really important about refeeding syndrome is if someone's experiencing it, most people's gut reaction is, okay, let's eat and let's fill their body with nutrients to correct it. That is just as damaging as not feeding them. So it's a very slow recovery period that we have to slowly increase their calories of about 150 to 300 a day, maybe weeks at a time, to get their body back to the electrolytes that they need. Sometimes with refeeding, we need feeding tubes. So we're not doing oral feeds. Other questions about refeeding? It's very scary. And there's absolutely the medication that we need and skills. If someone's going through refeeding, we really want them at the hospital level of care. Or any questions about the other medical concerns. Like I said, I'm not expecting you guys to understand all of them or certainly not memorize them, but just knowing like what the impact of our intake can have on our body.
Jessica is asking, are there any tips for identifying the differences between food restriction as self-harm versus one of the disorders?
Great question, Jessica. Yes. So some patients utilize their eating disorders as a form of self-harm, where someone might feel, I'm suicidal and want to die anyway, so why would I nourish my body? What's important is that we're doing mental status exams on all patients at all times to determine their quality of life and where they're at with depression and suicidal behaviors. Self-harm also could be used as a form of kind of like a drug, whereas it feels good. So I'm not worthy of feeling good. So I need to harm my body in some form. So in order to identify the difference, I would say it's definitely looking at the implication and reason behind the restriction of calories or the use of compensatory behaviors. And that's why dietitians love working with therapists and psychiatrists and psychologists so they can help determine that behavior as well. If there's a concern of one or the other, there is a chance that they are related.
Two more questions if you'd like to
Okay,
take them now.
sure.
One from Nancy, is overeating the same in terms of self-harm?
Yeah. Good. Yes, absolutely. Thanks, Nancy. It's not just the restricting or compensatory behaviors. It could be I'm feeling happiness and I want to numb that. So I'm going to fill my stomach and my body with food that I now become numb. It's kind of like a food coma. Absolutely.
And then Emily had a comment with
Mhm.
amenorrhea being on the list. It's interesting identifying a lot of overlap or correlations with symptoms you listed and hormonal issues in women.
Yes, absolutely. So a lot of times when we're in session, I'm asking where they're at with their cycle. What's amazing about the body is the body knows, hey, if you're not taking care of yourself, you cannot be taking care of a baby. So it really changes the cycle and the hormonal stages. And unfortunately, it takes a lot of time to recover from that as well. So someone who's 13 or 14 might not find that a concern. And they're like, hey, actually, I get to skip my period. Where we know that there's a lot of medical risks of not allowing our body to have that natural cycle. During their cycle, we often see symptoms increase the week before their period. So, if we're able to track those, the more information, the better. And we can work with the medical team to potentially increase or change medications or use a PRN medication the week before their cycle. And just knowing as a female, our bodies might have different hunger and fullness and energy levels during this cycle. So, trying to figure out the difference between an eating disorder behavior and a physical behavior. So, a lot of conversations around that. Thanks, Emily. All right. So common behaviors. I just wanted you guys to be able to see, maybe you're seeing some of these. I just want you to pause. If you're seeing some of these, it doesn't mean there's an eating disorder diagnosis, but maybe we need to do some investigation to rule it out. So here's just a list of things that we see that are common either at meals or avoidance of foods. If you guys are all, if some of you are in the school system and being able to recognize some patients, or sorry, students, maybe skip lunch completely, or they're hiding at lunch, or they attend two lunch periods. Um, when you're eating a meal with someone, it's good to maybe just be aware of some of these behaviors to see if there's anything going on. We never want to shame someone if they are engaging in a behavior like this, but I always like to, instead of the word questions of like, how or why are you doing this, use curious questions like, hey, help me understand. I noticed you put half of your sandwich in your napkin and threw that away. Can you help me understand what that was like for you? Maybe they're just truly not hungry. Maybe there was a bug in their sandwich, or maybe it's because they're trying to hide the food. So curious questions are always helpful. We don't want to create any shame. And we're going to talk a lot of that when we get to the body image portion. One thing to note down here, inadequate fluid consumption. When we talk about restriction, that also includes fluids, where someone might be trying to, impact their weight by not allowing any fluids in their body because they don't feel that it's necessary. Or the opposite of water loading. So they no longer have physical hunger, so then they don't need food. So both are closely monitored when working with a patient with an eating disorder. All right, so now we're going to get into the body dysmorphia. Is everyone okay moving on from eating disorders to body dysmorphia?
I have one more question for you from
Sure.
Jacqueline. How do we determine if it is water loading or a symptom? Hold on, I just have to go down a little bit. A symptom of, I can't get to the bottom of it. Could you talk more about water
Let's
loading and the
see.
difference between?
Sure. Oh, I see. Some medications. Yes, some medications will cause increased thirst, but also some psychiatric medications need increased water. So medications are reviewed by dietitians and they are looked at to see what fluid changes are needed. And when we determine a meal plan for a patient, we come up with their specific calorie needs in a range, and we also include their fluid needs. With that said, we never tell the patients, I shouldn't say never, but hardly ever are we going to tell the patients their calorie range. We're going to show them what that looks like on a plate. And we use the exchange system. If anyone's familiar with the diabetic exchange system, we use something very different. So say I was going to make a meal plan for Lori, I wouldn't say I have you on a 2,200 calorie meal plan. I would say throughout the day, I need you to have 6 servings of protein and 7 servings of carbohydrates and 8 servings of fruits and vegetables and fats, whatever that would look like. Because if we get focused on the number, that's often working with their eating disorder, and it becomes a challenge. So in regards to fluid, we do the same thing. So are we having an excessive amount of caffeine? Are we having extreme thirst where we're drinking water all day, but our tongue is still dry? That's a sign of a medication side effect. So a lot of it just goes back to the curiosity of what the symptom is doing. And a lot of patients have no idea that they're engaging in that behavior. And that's why it's important for us to ask about it. So with some of these questions, I feel like I'm not giving you guys a very specific answer, but that's exactly what mental health is. So body dysmorphia. So body dysmorphic disorder, as known as BDD. Sometimes you just hear body image, poor body image. I struggle with body image. That could mean like a whole clump of things. So it is related to the obsessive compulsive disorders within the DSM-5 class. I want you guys to know what it is. It is excessive, it is treatable, and it is recognized by the DSM-5. What it's not is it is not self-inflicted. It is not weight, gender, or color bias, and it is not treatable overnight. So what I mean by those things is when we're looking at the excessive component, it is something along the lines. It's more than me just saying, "Oh, I don't like my body. I'm uncomfortable in my body." It's me saying, "I don't belong in this body. I can't stand my body. I don't like wearing clothes. I don't like seeing myself. I don't want others to see myself. How I view myself in the mirror is likely not at all how you view me." So it's a very disordered. So if you guys could think of, if you've ever been at like a circus or museum where they have like that disordered mirror, imagine it being like that, that the facts are not available to their eyesight. So someone who is, let's say we can prove on a scale they're 150 pounds, in their mind, they have the body of like a 300 or 400 pound body. It also could be vice versa. Someone who's in a 300 or 400 pound body could feel that they see themselves in a 150 pound body. It does not go one way. And with that, it's not specific to any age, gender, weight, ethnical background. It is very diverse. It could be a focus on hands. I cannot stand my hands. I don't want anyone to see my hands. These are not my hands. They're not connected to my body. And the harm with all this is someone might try and change it, okay? Where they feel if they could impact their weight, they'll feel better about their body. So if any of you know, if you've been on diets before, you have gone through periods of not liking your body and maybe liking your body after you lose weight. That sometimes is still never good enough, where they are wanting to keep going, where, okay, I just need to lose 5 pounds and I'll be happy. Or if I lose 10 pounds, I will start hanging out with my friends. But then there's no way of stopping it. It is absolutely treatable. Just along with the rest of mental health, it's important that we have a whole team. It could be treated with anxiety, depression skills. It could be used. So we do a lot of like CPT or DBT, where we're treating patients with, we're providing them skills that they can use when they're having these feelings. So sometimes when I work with someone who's new to just discussing body dysmorphia, I'll ask them to put things on their mirror. Either they wrap their mirror in like wrapping paper, or a bunch of post-its and signs like "you are worthy," "you are loved." Maybe they ask others to put some post-its for them. So I'll literally give them a stack of post-its. So when they're looking in the mirror, they might see their face and they might say, like, "I cannot stand looking at this face. But not only do I see this face, but I also am associated by these signs." Um, I encourage people not to have diet pictures in their house of like what their goal body is, including their own. We also have like what we call sick clothes of, I used to be a size 6 and I'm going to hold on to those jeans. And that might not be a realistic. So I tell them if we could get rid of our sick clothes, we're not having this um, expectation for ourselves that might not be appropriate for our body. You might not have been in a healthy body when you were a size 6. You might be at a healthier body at size 12. And that's what we're going to make our goal. A lot of time it's not about the weight on the scale because they can't connect those dots. So it's definitely like perception is an important word for this. And no matter how much work we do, they can't see what they're doing because of the negative impacts until we start teaching those skills. Another important thing about body image is, unfortunately, we can't even work in and dress on it if we're not nourishing our brain. So first and foremost, we need to be sober from any substances and nourishing our brain and our body as best as we possibly can. So then we can start doing this hard work. So I'll talk about that when we talk about the levels of care. Lori?
Linda has a question. What about
Okay.
young boys ages 11 to 13, not
Mm.
liking their body, not eating because they want to look buff like the actors or football players they see? They are not understanding the harm they are doing.
Linda, thank you for bringing up sports. This is a topic that gets me really heated, and I would love to work with the athletic directors at schools talking about the pressure we have on these young kiddos with needing to perform, and in order to perform our body has to be perfect. So there's so much stress on these students, and a lot of it's coming from families, coaches, peers, and social media. So we treat them. It is, like I said, it's not always common that it's a male, but we're seeing it more and more. men have just as much concern of their body as women do. What's really important is that we're not putting an emphasis just on what their body looks based on how they can perform or be considered like good. So, just like when you do something at school or in a sport and everyone's cheering that you did something good, that feels really good. So when you don't do that, you have this expectation of yourself that you're not good enough, or I should say, perception of yourself that you're just not good enough. If we keep sharing that story with them, it's going to be true. So we have to work with them to understand that quality of life is so much more than what we see on TV or these professional athletes. And someone might look healthy and happy on TV, but we have no idea what they've done to their body to get to that place. It might not be considered healthy. Another thing with that is like these energy or not energy, workout drinks, pre-workouts, caffeine. I know they come in like bars and powders and drinks, all these different kinds that young kids have access to. What scares me about that is it's like a fake sense of energy to their body that they're not understanding that they need to refuel. So they might do all these pre-workouts, go work out, and they might not feel hungry, or they're tracking their calories, but they didn't take in account that all the energy that they just lost through that workout. And then we just continue the cycle. Anything, Lori? Anyone questions about body dysmorphia,
No
body
more so
image?
far.
Okay. Some risk factors. If someone has a history of body dysmorphia in their family, there is a chance that that is going to develop to younger generations, because I can give you one example of a meme. It is a mom standing on a scale and a little kid standing on a scale next to her saying, "When I grow up, I want to be just like mommy." So it's not necessarily the mom saying things to the daughter, but we pick up on these cues. Kids are very intuitive. Or they're saying, "Hey, family goes out for ice cream and daddy doesn't get ice cream, so maybe I shouldn't get ice cream either." So it might not be a direct message from the family, but it's the behaviors. If it's a standard in the family that we all have thin bodies and dress our best every day, that might give pressure to other kids to, change their bodies for that. OCD, because of the behaviors and tendencies with OCD, it could impact their food and body. Of course, eating disorder, depression, PTSD. If someone was abused or bullied about their body, they're absolutely going to be at a higher risk to develop body dysmorphia. Adolescent ages, because our body is changing. Imagine what our bodies looked like when we were 8 versus what our bodies looked like when we were 14. That's a short time for our body to change quickly. Whereas from 40 to 46, we might not see as significant of a change. So, depending on maturity level and understanding and anxiety and depression, someone might not be able to handle that just as well. Social media, I'm not even going to talk about because that will take me 5 hours, but you guys understand the implications of that. Lori?
And then Melissa asks, can you talk a little more about how body dysmorphia relates to OCD?
Sure. The thing with OCD and body dysmorphia is it might look like so what we know about OCD is having like this need to control certain situations, whereas the OCD might be strong enough that they're feeling like they also need to control the shape and size of their body. So if they have, for one example, it could be, I have to wear an even size pants, or I have to wear a small, and my body's not allowing me to do that. It's trying to figure out, is this an OCD behavior or is this a body image concern? It could also be certain foods and textures that they're consuming because of the OCD that is resulting in the body image that they don't want. So they keep striving for more and they're not understanding the correlation between the two. It could be just a matter of, because of the OCD, causing other emotion of anxieties and depressions. That one thing we have control of in our life is food. We might not have control of the weather, who's in my class, what my salary is, how my dad shows up drunk every night, things that we don't have control over, but we do have control over our food. Anything else?
Another question coming from
Mhm.
Jessica. Do you know of any research being done on postpartum depression, anxiety, and BDD?
Good question, Jessica. I do not. I'm sure it exists, and I would love to add that to my like wish list of things to look into, and I'd be happy to get it back to you and share you some resources for you. Lori, would you mind taking down Jessica's name and first and last name for me? Thank you. All right. Moving along. So common behaviors, over-evaluation of shape and weight, body avoidance. So maybe they're avoiding looking in mirrors, or maybe they have an excessive amount of looking in mirrors. One patient shared with me that her rear view mirror is always pointing at her face, not the back of her car, because she needs to check it constantly to see what her body looks like. Avoiding pictures, body checking where they're actually grabbing parts of their body and trying to measure, like always after they eat a meal, maybe they measure their wrist to make sure it hasn't changed. But it's definitely very unrealistic. This is some data I want to share with you guys. At SunCloud, we are very about finding, doing research and data so we can learn and adapt and be able to help best support our patients. So this is where we use outcome surveys for when patients admit and when patients discharge, and we can plug them in throughout their stay if needed as well. So we have the EDQ, which is an eating disorder behavior survey. We give it to all of our patients with a history of eating disorder, or if we're trying to rule out eating disorder. So you do not have to have an eating disorder to have body dysmorphia. You do not have to have body dysmorphia to have an eating disorder. I want you guys to recognize that. And this is just some data showing that some patients without an eating disorder still have shape concern. Some patients without an eating disorder have weight concern. So it's a matter of how much is this impacting our general mental and physical health on where we plug it into their treatment plan. Next one is showing with substance use. So same thing, you don't have to have one to have the other, but at SunCloud, we treat co-occurring, we treat eating disorders, we treat substance. So we're going to look at the connection of all of these because it wouldn't be helpful to come treat your substance abuse and completely ignore your nutritional status or your evaluation of your own body. So here are the correlations between no substance use and shape concern, as well as no substance use with weight concerns. You can see this one is a little bit closer when we have a substance use concern. One thing about substance use is keep in mind that someone who is actively engaging in substance use on a daily or weekly behavior, they don't necessarily have the brain capacity to nourish their body. So when they're sober, they have some of these feelings because they had that loss of control. All right, this is something fun I want to share with you guys if you haven't heard before. We have the genderbread person. It's a way to show that there's a huge difference between identity, attraction, sex, and expression. So we have some of our younger generations that are using these terms often, and they find it very helpful to be able to feel like they are able to finally connect to their body. So if you guys don't have some of the experience, I know schools that I've talked to have done such an amazing job in making this an all-inclusive topic for the schools, but just something important to share with everyone. So I encourage you just to Google the genderbread person. I use it as activities, but then also we have some common terms that are important to know. When we are working with some of the younger patients, they have a hard time understanding their body dysmorphia because they're not having a good understanding of how they can identify to one of these things. So we do talk a lot about this at SunCloud and within the school population, which I find amazing. I know I'm moving a little bit along quicker now. I don't want that to come off as these topics aren't important, but I could, like I said before, I could talk for hours. So I'm just trying to be mindful of everyone's time. Here's our levels of care. So within the mental health field, we have 5 levels of care. Outpatient would be similar as like going to school and meeting with the social worker, that it's maybe 1 hour a week, two 30-minute sessions a week, and we're touching in and implementing skills. Intensive outpatient program, IOP, is like an after school program where someone would go for several hours a day to have that one-on-one treatment for individual sessions, either daily or weekly, as well as group therapy to understand the development of skills, to sit in process groups to understand why are we feeling the way we're feeling and get some understanding so then we could start implementing the skills. Level 3 would be partial hospitalization, similar as PHP. And instead of like an after school program, this would be like a 9 to 5 school or work program where you're taking away the responsibilities of some of those other things in life and focusing on primarily your mental health. So when the difference between IOP and PHP is just a longer day. So you're provided with more time to process things, have individual sessions, have meals and snacks with someone, as well as your skills groups. Then we have residential treatment. This is where someone is not safe to live at home. They need that 24-hour care in a group program where they're going to be there overnight to work on. It's important to see we have 21 meals in a week, that it's really important that we're working with that patient 21 times, as well as 21 times for snack. So it's 42 opportunities to have a meal with someone so we can understand what some of the behaviors are and work through that. And then the last one, which is not a level of care that we offer at SunCloud, is inpatient hospitalization. So maybe this is someone who needs a feeding tube, or someone who's being refed, or someone who their labs are really concerning and we can't treat it at that residential level of care. We do have nurses and doctors on staff for the residential, but this is more of your body is going through a really hard time. So we need you to stay in a hospital bed all day. So this is usually our goal is a short stay, or our goal is to have to avoid it. So someone can move up and down these levels at any time, because all of these levels should and hopefully do include the therapist, a dietitian, a medical doctor. The patient is the primary focus of the treatment team, family, schools, peers, all of the above. Lori, any questions on these levels of care?
No, I do have a question, but Becky would like to save it to the end.
Sure. All right. So school interventions, for all of you that are working in the school system, these are some things that can be helpful. So snack and meal support. Sometimes I'll work with a patient. Think of like a 15-year-old boy walking into the lunchroom and having so much anxiety and social anxiety, and now having to eat a meal that they don't want to consume. So maybe having their meal, we've done the social work office, the dean's office, and the nurse's office, where those patients felt that it was a safer place. Another one that's not, that's a good place is the library, because it's quieter. Maybe they sit in the library with a peer. So they don't have a staff member sitting with them providing meal support, but we're just creating a more inviting space for them to have that challenge. So let's use snakes or spiders as a common fear. Imagine you are, deathly afraid of being in the same room as snakes. Now I want you to be in the same room as snakes 6 times a day for your 3 meals and your 3 snacks. In addition to that, you have social anxiety and don't want to be in your school cafeteria, and I'm asking you to engage with these snakes at the table at your school cafeteria. That's a lot of stressors in one moment that maybe we can remove some of them. So sitting in a more conducive space is helpful for some patients. Or it's asking the patient to go to someone who could hold them accountable to have their snack, because there is no supervision for that. We've also had some parents come every day to provide the meal and snack. So some of that might just be some work with the school to give them like a little bit of time during passing period, or be excused from the class for a certain duration of time. We also have patients who are not able to attend their physical education class due to their nutritional status on their body, that they do not have the ability to expend any additional calories. The school is, very important part of the treatment team, because we can see from you guys what things you're noticing. So we would have weekly communication with the school as appropriate and as needed for what you guys are seeing, what the patient is experiencing, and how we can work with that. Last is kind of a job for all of us is awareness in the classroom and just awareness in the world. We're so quick to judge, and that results in shame and guilt and bullying. That if we have awareness of, it goes back to that curiosity of why someone's doing the way they're doing that behavior. If we understand, we can be supportive. So instead of the quick judgments or the laughing, so it's just really important to also stand up for the students in the class if they, have to leave to go to the bathroom, or if they are having snack in class. That if you, notice anyone else doing any type of behavior that could be counterproductive to the recovery, it would just be very helpful. So talking about eating disorders and substance abuse at school is extremely important. And then also telling them like help is available. They don't have to feel alone. All right, so Lori, the last 3 slides are some activities that I can put on hold if there's questions you want to share.
Yeah, I have a question from Jacqueline. I had a client who had so much social anxiety that they would not eat in the lunchroom and was diagnosed with anorexia. Um, However, the school said unless they had a diagnosis of autism, they could not eat elsewhere in the lunchroom. Is there any form that the
Hmm.
team can present that will help schools facilitate these accommodations?
That's very interesting. I wonder where that came from and where that message was maybe lost. Um, I, I'm sorry, but I don't have a good I don't have a good answer of why that can't be accommodated. I think it's the importance is educating the people making these decisions of why these little nuances are so important to the patient's recovery. So then we can again avoid like the residential level of care, or the inpatient level of care, or even PHP, which is going to get in the way of their learning. So if we're not able to make these accommodations, it shouldn't be like a 504 or an IEP accommodation. It should be a simple, like, hey, this is no different than if I was allergic to bees and I needed the nurse to have an EpiPen. So always try and bring in the professionals. We have our medical director of our adolescent program is always open and available to talk to the schools about why these accommodations are important. Um, and hopefully the team could come to an agreement.
Yeah, and then she says that she did send a letter. She said maybe we just need more psychoeducation at schools, and that's where I come in and Colleen comes in and the rest of our experts. That one of the things that we offer is we will come to your site, offer free education for staff, for parents, and for students. So just
Lori,
know
remind me
as
the name of that question.
Jacqueline.
Jacqueline, I just want to say thank you for advocating for that patient. And please don't give up.
And then we have one more question from
Uh-huh.
Jessica. Can you discuss any connections that you're noticing between the recent increase in weight loss medications, and the impact on disordered eating trends?
Yeah, great question. Hot topic. So important because our society has taught us what's the quickest way to do something. So no different than what we've seen in the past. What's scary about this one is when we're on a diet, we don't necessarily need to add a chemical to our body. Whereas if we are adding these chemicals, it could be scary because yes, like things like Ozempic were made for a reason. But that doesn't mean it's for all bodies. All foods, all medications, all therapy approaches do not fit for all bodies. So the research is going to be hot and heavy very quickly that we're going to start to see some of it. But right now, people are focused on the significant quick weight loss, which often when we have that significant quick, it is that lack of control or the desire to control, the need for more. It's not good enough. And then it's going to start developing potentially some of these eating disorder behaviors. So we do talk about diet pills and weight loss medications when we're screening a patient to see if that's something that they have in their history. Um, they are unfortunately are becoming more readily available, and we likely are going to see some negative implications given what we know about the body. Anything else, Lori?
Yeah, from Samantha. Is it appropriate for school staff members to log how much a student has eaten or have one-to-one monitoring?
that would be a dream for the treatment team. If you're able to observe and monitor some behaviors, that's so helpful when you're talking with the treatment team of like, hey, I noticed that, when the patient brings their own lunch, they're able to consume 100%. But if it's a lunch provided by the school, they're not able to. Or I notice when this patient has a test the same day, they're not eating their lunch. So to have those facts on paper in a food log would be extremely helpful. One thing we don't want to do is share those food logs with patients. Some patients use it as motivation, which could be really helpful. Like, hey, I only got 80%. My goal is 95, so I'm going to work harder tomorrow. Whereas, unfortunately, for some patients, it might be my goal is only 75%, so I better be below 75%. So, if you can record that data and share it with the treatment team, that would be so helpful. Some patients do have access to an app on their phone that records some of this for them, but it's self monitored and self recorded.
Okay, we have another question. Do
Mm-hmm.
you have any tips for working with schools when they seem burnt out for caring for a certain child? I've run into this issue a few times where one child needs consistent care and the school
Mm-hmm.
starts to give up on providing the accommodations that were recommended because they label that kid as a problem child.
Yeah, sad. I'm sure you guys see this a lot, but you guys are also doing so much, and I can't imagine what it's like to, be caring for hundreds of students. But that's where it would be really important to give the recommendation to the family that, we just want them to have the help they need, and that might be outside sources. So if we can take a break from school and get them the treatment they need, and also continued education with the staff of what burnout looks like, because that is a real thing for
Mm.
everyone. And where those things are that we need to plug in to be more supportive for the patient. So it's working with the school and the family to provide that support, but then also educating the staff. I know some of you might have to hop off, and I totally understand and appreciate the time that you have come. But those of you that can stay, if it's okay, Lori, if I finish just providing the resources.
That'll be great.
Okay, so this one is 10 lies eating disorders and body dysmorphia tell you. This is a resource that I've used for years where it's 10 lies that a body has told someone. So it's, for example, you take up too much space. Any space is too much space because you are unwelcome, uninvited, inconvenient, disappear. So this might be someone's truth where this is factual for me and this is what I believe and this is what I tell myself. So I challenge patients and students and people of the community to change those words. Like, take up space. You are worthy of that space. Any space, you're welcome, invited, convenient, and we want you to appear. So this is one task that I give. You might just ask some of the patients of, hey, what are some truths your eating disorder and your body dysmorphia have told you? And now let's debunk them and come up with some healthier truths. So that's a great one that I've used with patients. Next one is securities and insecurities. What I do with this is have someone draw just a body outline on a piece of paper. It doesn't have to be specific to their body, but on the outside of the body, I want them writing insecurities like I am not worthy. I am a terrible football player. I am not loved by my family. My feet are massive. Any of those insecurities. Whereas on the inside, I want them to write their securities of it could be neutral statements such as I play football. I have 2 feet. I love my feet. And as we're working on their recovery, we're slowly ripping off and cutting off and chipping away those insecurities and proving them not to be true. So then the goal is when they're done, they're left with just the securities inside their body shape. So it's a good experience for all of you to do on your own, as well as with maybe a student or a patient. And then the last one's a video, but what I wanted to share, one thing I forgot to mention, was when we're working with body image, we need to be making sure we're nourishing the brain and having facts. That's really important for them. So sometimes they just might not be ready or appropriate for that. So you might not experience body image recovery until we're at the later stages of their treatment, which I consider like the gift. Like, okay, you've done all this work. Now the gift is we get to work on body image. And then last, if anyone has the time, I highly suggest you Google best friends get brutally honest with their bodies. There's a YouTube video that Dove um, released years ago, and it is a very moving, empowering video that if we were in person, I would have us view it together and then talk to each other that same way. So it's a very powerful video that I just wanted to be able to share with all of you. But for sake of time, I'll let you do that on your own time. So, Lori, I'm done if you want to share any more
Oh,
questions with me.
well, I don't see any. I do
Okay.
have some questions regarding where we go from here. And of course, we hope that you have benefited from all of the really important information that
Yeah.
Colleen was able to share with us today. And she's a wealth of knowledge and experience. Something that we want to take from here is that you know that you can contact us.
Mhm.
I'll be your key contact for setting up more educational offerings like this. It doesn't have to be a CE. It can be coming to talk to your social worker team, coming to talk to your practice, finding out how we can best serve you in that way this year and moving forward. We want to find out what you need to learn about
Mhm.
mental health issues, even staff development in terms of their own wellness and coping skills, et cetera. We're talking about the burnout. We all need as many resources as we can, and all of these are offered to you free. So please utilize us, and we would love to come out and be on site with you. Um, Again, if you have a referral in mind, if they come up, if you need to direct families, give them my number. I'd like to be able to help answer questions for them related to what treatment looks like, why it's so important to intervene early. And so we
Mhm.
just want to be a trusted resource to you. Thank you so much. We did have a question. I'll field it to you, Colleen, through Becky's email. And again, you will all receive an email to complete your CE certificate. And with any questions, please email me. You will get copies of the slides, the PDF, and this has been recorded, so you should be receiving the recording as well. Anything else you want to add to that, Colleen?
Just appreciation that you guys took time to be willing to learn about this because I know you're likely doing it to help someone else. So that speaks a lot to Lori and I and the rest of us at SunCloud that there's so much work to be done and we all have to work together. So we create an alliance together. So thank you for just being available for the rest of the loved ones in the community.
Yes, thank you all so much for the important work you do. And I noticed a question, when will you receive the email? In the next few days. And then we will all be reaching out to you individually, or I will, to follow up with you. So thank you all
And
so
thank you,
much.
Lori. You're a great host. Everyone have a good rest of your day.
Thanks, everyone.